Welcome, everybody. My name is Pat Kuhn. I am one of the tech consultants with Ivoclar Vivadent. I'm going to kind of be moderating the event this evening. There will be CE for this event. You should, after the webinar is over, you should get an email with a link to go out and do a short quiz, and then you'll get your credits via email from that. I'm going to hand over to Mr. Mike Lawler. He is one of our key account managers for Ivoclar Vivadent. Mike? Mike, you're on mute.
Thank you. Hello, everybody. Excited to be here in New Albany, Indiana at Kelley Dental Lab. We've got a wonderful presenter tonight. It was going to be me had we not had this COVID situation. You've been spared that tonight, and Don Yancey is going to do the speaking for us. Don's been with us for 20 years at Ivoclar, and before that had his own removable labs. I was in the Navy as a technician as well. He's an Alliance dental technician, prosthodontist, and he doesn't like to talk too much about his past. He'd rather you hear what he's able to share rather than hear about what he's done. So I'll
turn you off the air conditioning. Thank you for letting me come in to see everyone. I appreciate Kelley Dental Lab for allowing me to also do this. Thanks to Michael Lawler, Dr. Sashi, Chris, Pat, and Linda's in the background, and hopefully we'll get through this, but we are having some difficulties. I promise you I can make a denture better than I can do this, this webinar, so thank you. So we'll get started. The agenda tonight is really a good one. We've made removable such a challenge that it's time to make it simple. It's really not as hard as we've all been taught. So we will be talking, doctor laboratory communication. I think that's the most important thing, and to have the tools to do that. We're also going to be able to try to come up with a way of, making an objective vertical dimension. It is such a subjective category that I think when I get to that section, you'll remember dental school and how that was all presented to you. Then we're going to try to do some denture tooth selection, do the right width and the length. And then I want to be able to help you nail the aesthetic plane and the occlusal rim. And then choosing the right teeth for your patient, and of course, questions and answer. If I start running late, I may drop a few things and move on forward just so that you guys can get finished with your night without having to listen to me all night. So let's get started. If you look at this before and after picture, this is an amazing patient that we had at UNC with Dr. Cooper and one of his pros residents. And it was always nice every year I get to go to the universities to do that, the same as here. But we're very fortunate here at the center that we do teach the pros residents every year, the AGD, and of course laboratories and dentists come also. And this is the one year that we went, and the young lady on the left had been totally abused over the years. She had remarried a soldier who was over in Afghanistan at the time. And, you can look at her picture, and even though, her eyes kind of look like she's happy, you can just tell that that smile was hard and forced. But when you look at the picture on the right, we did full upper and lower immediate dentures on her, and look at the difference in her face. I mean, it just made her so much happier. If you look on the left, she's definitely square and overclosed. When we get the vertical correct, use the right size teeth, and use, good looking teeth that look so natural, it changes a person's life. While we were there at the chair doing the try-in, this is actually a picture of the try-in. We had the patient, we told the patient this is going to be a big deal. We would like for you to dress up. We wanted you to come, as pretty as you can. because we wanted to make this a big deal. This is dress rehearsal. You should always make try-in a big deal for your patients because this is very important for them. This is the first time they've been able to see themselves with their new teeth. And so this was a try-in. She started crying. She got on FaceTime with her husband over in Afghanistan. And it was just an incredible scene to be able to be part of. So it's really quite nice. So the communication here was absolutely perfect between the doctor, the patient, and of course, the technician. Here's another picture, another success story. This is Kelley, and with this, she turned around and already had some upper and lower dentures, and they were all on fours. And she'd had them for about 2 years. So the picture on the left is what she was wearing for 2 years. She was very, very, very happy with these, and so happy. In fact, you know, we saw her blog. She was talking about how nice her teeth looked, how she could eat anything she wanted, and she had over 500,000 people following her. It was just incredible. So our marketing director, Grace, actually called her and said, we would like to give you some new teeth with some Ivoclar teeth. And she flatly turned us down. She said, no, thank you. I'm happy with what I have. Well, we kept telling her that, you know, you don't have to worry about this. We'll make them. If you don't like them, what's really nice is we unscrew what you have. If you don't like what we put back in, then we take them back out and we'll screw yours back in, no problem. So she finally agreed to it. And then if you look on the picture on the right, of course, you can see the big difference. The teeth on the left are a little small. They don't have vitality. They don't look, you know, as aesthetic as we would like. And now she's wearing some Veneris teeth, and you can see how natural they look. And you can see her smile, and you can see her eyes light up. So it's awful nice to be able to be part of this. Looking at her from a lateral view, look at the smile. Now notice her chin. She is actually a class 3 skeletal patient, but yet we have her in a class 1 occlusal setup. So, you know, this is one of those things that, you know, you don't always have to do a patient in a class 3. And she was already in a class 1 with her previous all-on-4. And so she was adamant that we were going to put her back in this position. So we did. And again, you know, you can see how nice the profile looked. The communication was really good here also. Here's what she was wearing on the left. You can look at the tissue. The tissue doesn't look very natural. Now, this case is only 2 years old. And then if you look at the picture on the right, look at the tissue. You know, everything that you're looking at this, not only does it have to have a good dentist, not only does it have to have a good patient and a good technician, but it's so important to have the natural teeth and to have a process system that will let you process these to give you the full package. And this is what you know, we were doing with this patient. Here's a close-up view of this. As you look at these, look at the picture on the lower right. Look at the nice anatomy of the labial surfaces of these teeth. These are the Veneris 2s, and you can see how nice they look. Look at the shapes. It is a very natural shape. You would never know that she is wearing a full, you know, full upper and lower denture. And that's what we're really looking for. And you can see the, you know, the acrylic. It is customized for her. You know, we have a little bit of tissue tinting going on there. And it just gives you a much more natural look. Now, of course, with this picture, now we're going to get into no communication, because we want to explain how important that communication is with you know, Kelley Dental Lab. You know, these people are totally trained. They know how to do this, but we've got to have the communication between you and the patient, and then back to the laboratory. It's vital. If you look at this, now we're going to the Buffalo VA. The reason why we're at the Buffalo VA, and these teeth were not made by the VA there, Dr. Frank Laciello, which you'll be seeing him shortly in a lot of videos, because he's chairside showing you how to use all of these communication tools. So we went there one day and we started taking these pictures, and these people are there for medical purposes. But we asked them, could we look at their teeth and take pictures? And of course, if you look at the picture on the left, this particular patient is definitely a class 2 patient, but is he really that class 2? When you look at the upper lip, there is no upper lip. I think the teeth are a little too forward, plus they are pretty well taking up 2/3 of his inner arch spacing. So this wasn't done very well. The picture in the center or the picture to the right, you can look at this. I mean, he is banging into his lower lip, which he should not. You can look at the teeth where he actually took a file and he kind of ground his teeth to make them look more natural. The tissue is just showing way too much. It's incredible. The midline is off to the patient's left. All of this makes for totally a bad judgment. We asked him, did he like his teeth? Believe it or not, he said he did. He liked his smile. So I don't know if the dentists that made these in the laboratories were just listening to the patient or not. But as an armchair quarterback, I can see all the things that I would want to change. And so these are the things that we want to discuss. Here's another patient, same place. Again, Buffalo did not make these teeth, VA there, they didn't make these. But I want you to look, and I want to just bring out a few little points. And I want you to look, when you're looking at this smile, we even asked him, could he close his lips together? And he could not. The amazing part of this is, again, we asked him, did he like his teeth? And he just said, you bet. He says, I love my teeth. And we said, well, what do you like about them? And again, he said, I like my smile. He said, all my lady friends just love my toothy smile. But when I look at this, I think the teeth are a little too small. The tissue just does not look natural. And again, I think the inner arch spacing has been violated. And I always like to see something good. So when I look at this and you look at these glasses here, you look at the shape of the glasses, they did a great job of duplicating that with his smile. That's about all I can think of that makes that. Now, if you look here on the picture on the right, this actually came out in a newspaper. As you all know, we've been trained how to do our clinical manner with our patients. And we've been told to always smile, always be positive. When we deliver something to one of our patients, we're supposed to look at them and say, wow. If you're doing a crown, you go, boy, that crown looks so natural. No one ever know it's a crown. If you're doing dentures, you'd say, wow, these look so natural. You would never know that this is a denture. And you're supposed to always do that. Matter of fact, I had a crown, I had a big MOD that was remade just recently and made into a crown. And it's so funny. I'm sitting in the chair waiting for the dentist to come in, and the assistant had seated the crown, but we're just talking, and it's in the posterior section, so the dentist cannot see it. And my dentist looked at me and said, Don, that crown is just beautiful, isn't it? So that drives home my point. This is the way we're taught how to talk to our patients, and it was just amazing how I looked at her and I started laughing. I said, you hadn't seen it yet. And she reminded me that she had seen it on the cast, and it looked very good. So it's one of those type of things to do with that. So what went wrong with these last two cases? Well, big question. It's all about the communication, which is what I mentioned in the very beginning. So a lot of this is going to be communication. And when I'm going to do a denture, I don't really like to say that I'm going to do a denture. It's not just time to prescribe more than a denture. It's time to prescribe a smile. You are actually doing full mouth reconstruction with every case when you're doing full upper and lower dentures. Even in crown and bridge, it's kind of nice. If you're going to do full makeover with crown and bridge, at least you have natural teeth. You also have some crown and bridge there, and it's so much easier to find the patient's bite. With an edentulous patient, they do not know where they bite. And so it is kind of challenging. And I think with all of these communication tools, you're going to find out we're going to simplify that. And if you haven't been removable in a long time, I think by the end of this lecture, you're going to enjoy doing it, and it's going to be profitable for you. we've turned around and made a kit. With this kit, we've had the tools all along. I even had one of the pieces of this kit that I used to buy from a manufacturer just 30 years ago, and I used to spend $120, and it was called a Alma gauge. We've renamed it denture gauge. So when you hear us talking, and we sometimes instead of saying denture gauge, we'll say Alma gauge. They go back and forth. So but they're the same thing. So we apologize for doing that. But I used to pay, like I said, $120 for that one piece. We put everything together in a kit, and we absolutely do not make any money on this kit. And you're going to be surprised. The cost of it, if you want all the tools, is less than buying impression material. So you're going to find out that it's just quite amazing that we can offer this. But everything that you're going to see tonight with all the videos, it's on this DVD. And you're going to have a manual that goes over everything. And the laboratory does 3/4 of all this work. So you don't have to do a whole lot. It's just a few little tools. It's going to take you less than 7-8 minutes to even do all of the tools at the chair. But it's going to make all the difference in the world. Here's all the little tools. You probably have some of them already. I'm sure you may have a pupillometer. You may have the Alma gauge, denture gauge. You may have a rim former. Of course, you probably do have a Fox plane. You probably have some calipers. Most of us are probably going to use a tongue depressor instead of the calipers, but we're going to show how to do some of that. And then we're going to go over some more of the tools to make it easy. Here is our denture gauge, and I'm going to try to play this video.
The gauge comes with a little plastic covering. These are disposable, and actually is a nice communication tool that, as I'll show you, we're going to send over to the laboratory. Fits right over the base and kind of protects it and keeps it a little on the clean side. And we're going to put the patient's existing denture here, and we're going to record again communicate some information to the laboratory. And I'm going to take this plunger and place it down right into the center of the anterior papilla, which is usually quite noticeable in the patient's denture. And as you can see now, there's a recording. That means from that center of that papilla to the edge of the incisors of the teeth, it measures approximately 8 millimeters. Now I communicate that to the laboratory, and the laboratory will use that information appropriately because what I'm going to ask the laboratory to do, because I've had the opportunity to try this into the patient's mouth, and I realized that these teeth are shorter than I want the final teeth to be or the wax rim to be. So I'm going to take that 8 millimeters and I'm going to add 3 millimeters to it because I want my teeth to be at least 3 millimeters longer than what they are here. And that'll help compensate for the ridge resorption and the settling that has taken place. Again, the laboratory will also have an Alma gauge, and they'll have their denture base with the wax rim, and they'll make the appropriate adjustment of the wax rim to a 11 millimeter measurement on their particular Alma gauge. So it's a wonderful means of communication for that one element. Another area that can be communicated to the laboratory is the labial positioning of the teeth. And again, I'm going to hold this in a steady position right into the center of the anterior papilla. And what I could do is read this measurement anteriorly, which I'm going to tip this a little bit so we can see it in the camera perhaps a little bit better. And that measures around 10 millimeters. And that's telling me how far forward the incisal edges of our teeth are. Now, again, I have the option to accept the 10 millimeters or to increase that by several millimeters, depending on my clinical evaluation of the patient's existing denture. Again, in Michael's case, there's no question I want to pull these forward, minimum of about 2 more millimeters, I think, to help him give a little bit more lip fullness. And another way of communicating this is by putting a marker here, and I can now mark the actual labial position of the patient's existing denture teeth. So to complete our prescription to the laboratory, as I mentioned, our vertical measurement, the first measurement with the plunger up here, we measured at 8 millimeters. However, we're going to add 3 millimeters because I think the patient could use that extra incisal length. So to the laboratory, our prescription is going to be 11 millimeters for that vertical measurement. Horizontally, we measure at 10 millimeters as we see from the patient's existing denture, but my horizontal suggestion to the laboratory is to add 2 millimeters to that to make that perhaps a 12 millimeter forward position of the wax rim in this particular case. So this will snap off our Alma gauge, and this could be, you could put the patient's name on this and put this right into their case pan. That'll be sent to the laboratory and becomes a part of their prescription, and kind of a very nice essential part of the communication between you and the laboratory, taking advantage of the fact that the patient had existing dentures and we're able to make some personalized determinations to facilitate our communication to the laboratory.
Here, we're utilizing the patient's existing dentures. When we were going to school, you were always taught that not to look at the existing dentures, that there's nothing correct about them, so you don't want to look at them. With this, you have so much data with the existing dentures, it is quite amazing. So what you're going to want to do is to put the patient's existing denture in the mouth, look at them from the frontal view, have them smile. Do you think you see the right amount of teeth, or do you not? If you see the right amount of teeth, then fine. You can take that measurement and keep it the same. If you want to do like Dr. Frank does, that was in the video that you didn't get to see, if a lot of times he'd want to add 2 to 3 millimeters so that they could see more of the incisal edges. You have to make that determination. If you like what they have, you have to do nothing. You just measure it, and then you'll send these measurements over to the laboratory. So when you're looking at this person, if I'm going to go ahead and use the incisive papilla, and we're going to push this lever down into the incisive papilla, it's going to give us the vertical measurement. What it's telling me is from the incisive papilla to the incisal edges of the teeth, they are down 7 millimeters. Why do we use the incisive papilla? After we extract all of our teeth, generally on the maxillary, the ridges collapse inward and go upward. But with this, the incisive papilla never changes unless some reason why we would go in there and surgically and change something. So the incisive papilla, the hammer notch, is another area that does not change. The ridges change, but those two areas do not. So I would measure that existing denture and get the vertical, and then why I have this in that incisive papilla, I'll also look to the labial. So if you look here, the labial, it's also coming out. This reads like 9 millimeters. The vertical is 7. So that means the anterior teeth are from the incisive papilla down to the lip, to the incisal edge. They're coming down 7 millimeters from that incisive papilla. They're coming out labially 9 millimeters. So if I like that, great. We're going to give this to the laboratory. We're going to put that on prescription, give it to Kelley Dental Lab, and say, this is what we want. Please make the occlusal rim exactly to this measurement. So we're actually going to turn around and customize the occlusal rims to fit what you want, instead of you having to spend 30 and 40 minutes at the chair making those occlusal rims proper to get to this point. So this is going to save you a tremendous amount of chair time. Again, if you didn't like it and you wanted to bring the teeth out labially, or you wanted to bring them back, then this is the areas that you would do that. I would just put on the prescription. If I wanted to come 3 millimeters forward, I'd tell the vertical I'd want 10. And I would also, if I want to bring the labials back 1 millimeter, I would tell the laboratory 8. So it's going to give you a great position to be able to give that laboratory what you're needing so that you don't have to do this yourself at the chair. You pay the same amount for the occlusal rim, so you might as well make it to where you don't have to worry about it. So this is a great tool, and this is what I said I used to spend $120 on to turn around, and I gave every one of my accounts this, and small lab, I only had 40 doctors, and it was just well worth it for me to be able to do that. Your larger laboratories, not very feasible. But for me, it was feasible, and it stopped my resets by 90%. So I really like this tool. Now let's talk about the papillometer.
First thing I want to do is open up mic, please. And we're going to take the patient's denture out. And I'm going to take the papillometer. It's a device that's going to help us give the lip line communication to the laboratory. And it has a little device in the back of here that's going to rest against the anterior papilla. And where this meets the gauge here, that would be at the 0 point. In other words, where it rests on the incisal papilla, that'll be our 0 point. And when we press this into the patient's mouth, whatever reading we get here will be interpreted as a number of millimeters between the patient's anterior papilla and the patient's lip as it's recorded. Now we're going to go to the patient, and I'm going to put this gently under Mike's lip here. And again, resting this against the patient's anterior papilla, we're going to let the lip just very gently and gracefully assume its resting position. And as I look at that from my position here, I'm going to measure that at about 14 millimeters. Now I'm going to ask Mike to, that's going to be the patient's low lip line. And I'm going to ask Mike to give it a nice casual smile. Now we're about 9 millimeters. We're going to consider that as our patient's high lip line. So we got a difference between low lip line, high lip line of 5 millimeters plus. And give me a little more of a smile, Mike. Maybe I'll put that measurement around 8 millimeters. First, we're going to mark a dot right in the midline position of our maxillary cast on the land area. And again, in the laboratory, they're going to also have a papillometer. And what they'll do is they'll rest it gently against the anterior papilla of the cast, and then we're going to take a measurement from this dot down to the 14 millimeters, which was the patient's low lip line. And then we'll read our gauge, which measures about 33 millimeters. We'll mark that down now as our low lip line, equal 33 millimeters. And we know that our high lip line, when the patient smiled, measured at 8 millimeters. So there's a difference of 6 millimeters. So we could say our high lip line equals 27 millimeters, again measured on our scale. So that when the laboratory is ready to fabricate the wax rim, they will they'll preset this to 33 millimeters. And then when they fabricate the wax rim, they'll make the wax rim at that particular length. And then when they're ready to do the setting of the teeth and they want to do their final wax up, they'll preset this to 27 millimeters. And they'll make sure that the gingival wax up covers at least that much of the tooth structure. So it's a nice means of communication, some of this personal or clinical criteria to the laboratory to help in the process of setting teeth as well as the wax rim length.
The papillometer is my second tool that I like to use, and the papillometer actually does the same thing that the denture gauge did. I'm placing this on the patient's incisive papilla. And there's a little bitty lip here. I'll show you what I have. There is a little bitty stop on the posterior side, and that's at 0. And so we're going to put that on the patient's incisive papilla, making sure that this stays straight up and down. And we're going to take a lip measurement. It's just, you want to have the patient lick their lips, and you're going to just let it drape. And so you're doing the low lip line. Don't pull on it. If anybody has a lot of, a pull in their lip to where it's very flexible, you will literally pull it down instead of letting it be at a relaxed position. So make sure it's at a relaxed position. And then we're going to take this measurement. Now, what I want you to really notice is the difference between these two patients. At their low lip line here on the left is only 7.5. You look over here to the right, 19 millimeters. And guess what? We've all been taught to make an upper occlusal rim 22 millimeters long in the front, and most likely around 18 millimeters in the back, or 12 millimeters, according to what school you went to. And if you was to place that into this patient's mouth, you would have to reduce the occlusal rim probably the next 15 to 20 minutes to get it proper. With this particular patient, you would have to add it to it. I mean, incredible that, all this time, when all we have to do is to give these measurements to Kelley Dental Lab, and they will make you an occlusal rim totally customized exactly where you want it. And then at this appointment, you would just put it in the mouth and you would go through phonics. You'd want to say father, 55, 56, 57. You're going to want the occlusal rim to barely touch the lower lip when they say father, 55. If it bangs into it, then of course you're going to want to bring that back up. So you want to take a couple millimeters off of that. If they're not anywhere close, of course, then you'd want to add to it. But doing this and giving the measurements to Kelley Dental Lab, you don't have to do that at all. Over 90% of the time, you're going to place it in the mouth. You're going to have the patient smile. You're going to have to let their lip relax, and you're going to look at it and go, amazing. I mean, Kelley Dental Lab is just doing an amazing job. They just saved you 30 to 45 minutes in making this appliance. So it's going to be a good chair time saver, and it keeps the patient from having to come back for multiple try-ins, because generally you wait to do these aspects to figure out if your anterior teeth are too long, too short, are they too far out. You wait to the try-in. Such a waste. When you have to try to move teeth, it takes so much more time to move teeth back or bring them forward or bring them down. So we want to do this in the occlusal rim stage. This is how important this is. You're going to want this customized occlusal rim. In fact, we always call that an aesthetic control base, an ECB, because it is a control. We've got measurements, we've made it customized for the patient, and it's ready to go. But look at that. I mean, big difference. 7.5 on this patient, 19. Now in my next picture, I want you to look at the high lip line. Same two patients. High lip line on these two patients, only 1 millimeter difference. So high lip line is not an issue. It's always that low lip line that trips us up and causes us a lot of time and a lot of remakes and a lot of retry-ins. So only 1 millimeter difference. So if I go back, you look at the difference, 7.5 and 19 high lip line. Come here, only 1 millimeter. But still, I want this high lip line. Because there's a reason why I want this high lip line. When that patient smiles, if you remember in one of the patients that we didn't have good communication, all they showed was pink. I mean, it's amazing how much tissue they showed. And that's one thing that can really trip you up when we're doing dentures, is if the acrylic gets shiny and then the light hits it, it's fake. Everybody a mile away knows it's a denture. So we really do not want to show as much acrylic unless we have to. Some patients, they have a lot of geography there, and we're going to see a lot of tissue, but we're going to be getting the right length of a tooth. We can make sure to take care of that where they only barely see a little bit of that tissue. The real nice thing about this, all of these tools are also used in digital. So learning how to do these now analog, you're not wasting any time. And the amazing part about this is, of course, look at this. This is the low lip line right here, 13 millimeters, and it comes from the incisal pillow down to the occlusal edge or incisal edge of that occlusal rim. And that's exactly when you're getting your proposal for your teeth setup, it's put in it exactly. In fact, look at that, 13.001. I mean, it is a very exact when you're going into digital, but all of this is not a waste of time. It is really good for you to do. This next one is a bite gauge.
The bite gauge is a convenient tool that helps to measure the facial vertical dimension of a patient. The gauge can be used in two ways. It can measure from reference points placed on the patient's nose and chin, or it can be used without reference indicators by reversing the bite gauge so that one arm rests under the patient's chin while the other arm is elevated to rest under the patient's nose. The clinical demonstration will show the first mentioned technique. Adhesive triangles are placed on the patient's nose and chin to be used as reference indicators. The points of the triangles make a very distinct reference point and are much easier to remove than a pen or pencil marking. The patient's head is brought forward from the headrest. The patient is first evaluated with their existing dentures in place. As was evident with this particular patient, the vertical dimension is significantly overclosed. However, it's still beneficial to leave the patient's denture in his mouth while assessing vertical dimension. And they are encouraged to relax their facial muscles. Once it is certain that the patient is completely at rest, a measurement is made using the bite gauge. This measurement is considered the vertical dimension of rest. 4 millimeters is subtracted from this measurement to approximate the vertical dimension of occlusion.
But with the bite gauge, most of the time it's just a caliper, and with the calipers you would mark your nose and your chin, and you go through all of your motions, and then you would measure. You know, you try to get them to relax, open, close, whatever procedure you have, and you would measure, or you use your tongue depressor. I mean, you go ahead and you mark both of those on your tongue depressor, and you can do that. But the kit does have a nice bite gauge in there that is quite easy to use. And the nice thing about it is, you know, we've got our measurements, and we got our millimeter measurements here to where we can go nose to chin, and it'll give us our figures. Another technique that I really like to do with this is I can also turn this around. I really like this technique. And then we can look and we get the same numbers. So either way we do this, we get the same numbers with this. And then you could maybe do the tongue depressor and do everything. But the calipers are nice, but I could do without it. You know, if you didn't want to buy the whole kit, then you don't want to need the calipers, you don't need it. Now, I talked about earlier how vertical dimension is very subjective. If you can remember back in your school days, you had your professor, you got that occlusal rim, you spent 2.5 weeks making those first occlusal rims, and then you turned around and went chairside clinically with your patient. You put them in, and you were thrilled. They were just perfect. You went to your professor came over and said, no, Don, I think we need to close it 2 millimeters. And they would go about telling us how and why they were thinking this. Well, they would leave. We'd go looking for another professor, because we're always trying to find a professor that's going to agree with what we have. We don't want to spend another 30 minutes or an hour of redoing all of this because we think it looks good to us. So you get another one. That professor comes over and says, no, you know what I do? I close it 3 millimeters. It is just so subjective. So I want to give you 3 ways. If you don't have any issues with doing a vertical, I would tell you to just, right now, you take a short break. It's going to take me a few minutes and not even pay attention to this, but go ahead and just do something else, because I do not want you to change. In Georgia and in Florida, if it's not broke, we don't fix it. So I thank you for that. But so what I want to do, the first thing I like to do is I want to measure the outer canthus of the patient's eye. Just take one of the eyes. I measure the outer canthus, the V part here, and then I want to measure the inner canthus over here. So we'll just take some calipers and we'll measure from here to here, or you can use a ruler, and you'll get it something most likely in the 60s. Let's just say 62, if you'll try to remember that for me, because I may forget. And then I want you to do the patient's hand. I want you to take the patient's hand, and you want their thumb to be very tight. You don't want the thumb to be out here, very tight. They can even drop their fingers like this if they wish. I usually leave it straight up. And then you can ask the patient, you have them swallow and just relax, and then you let them take their hand. You've got to make sure their hand stays straight. You don't want it to be, canted. So you have it straight, and then you just have them come up. So if you notice, when my thumb hits my chin, so does my finger. And you already have dots on the nose and chin, and everybody always says, Don, where do you put the dots? Well, in the center, and with me, I got a center hole in my chin here, so it's easy. But just in the middle of the chin's fine. And so you have it marked. You have the patient do this a few times, or this, and then you just take a quick measurement. That could be 65. Just measure it real quickly. Then you can turn around and do what we call the exhaustive technique. Now, the exhaustive technique, the other two are very quick and easy, and you don't have to really train the patient to do anything. The one thing I want to mention, though, you got left hand, right hand. Some patients' left hand is bigger than the right hand's bigger than the left. So if you do this and you measure, and they're not in the 60 ranges, try the other hand. It may just be that hand is a little longer. If you have your female patients that actually have fingernails, it's not the fingernail, it is definitely the finger. So check that. It sounds kind of hokey, but you're going to be amazed how well this really works. Then we're going to take the exhaustive technique. Now, the exhaustive technique, I have to work with the patient just a little bit. I have to tell them that I'm going to have them take a deep breath, and then I want them to exhale, and while they're exhaling, go M, 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 M. And you're going to let them just keep saying M, 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 M until they can't hardly breathe anymore. You start seeing them turn purple. Not really. But you just want them to just keep going, M, 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 blowing out at the same time. Then they're going to take a deep breath, do it again, M, 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 M. Take another breath, M, 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 blow out. And then on the fourth try, you're going to want them to stop somewhere in the middle. So you practice that just once with them, and then you go to real life and you M, 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 stop them, measure very quickly. So you tell the patient that all I just want you to do is when I tell you to stop, just stop. Don't close, don't protrude, don't go left, don't go right. Just close and wait a quick second, and then you take that quick measurement. Let's say I get 67. I'm going to take the 62, the 65, and 67. Guess what number I'm going to take? I'm going to do the average. So I'm going to take the average of the three, and you got to remember this is going to be an initial vertical. So it doesn't have to be exact. It's just going to put you in a ballpark because we're going to actually take a preliminary centric occlusion to give to the laboratory. We've already given them measurements for the labial position of the teeth, the incisal edge of the teeth to make for their occlusal rim. So they're going to have that information. Now we're going to give them this arch. We're going to give them this inner vestibule area here. We're going to give them that inner arch distance right here. So that's going to be our 62, our 65, our 66 in there. And so they're going to make that upper occlusal rim, and then they're going to make the lower fitted. And so when we get it, the patient's not going to be wide open, nothing. I mean, you're going to be surprised at how much time this definitely saves you. And then again, you're going to start doing the phonics. Now we've got to take the vertical, and we've got to have some way of taking that vertical.
The autoclave centric tray is assembled by placing the edentulous supporting wings on the rail of the tray. The wings serve several purposes. They provide support for the putty registration material, and they also provide a place for the patient's tongue to rest so that it does not get in the way of the registration material. 2 scoops of virtual impression putty fast set are usually sufficient for most mouths. However, if there is severe resorption of the residual ridges, then 3 scoops might be necessary. The material is thoroughly kneaded until it is one homogeneous color. Separate the material into 2 sections and place them over the wings of the tray on both sides. By pinching the ends, it helps to secure the material into the tray. Now we are ready to approach our patient. Insert the loaded centric tray. Stabilize the tray over the maxillary ridge and support the tray with one hand. This frees up the opposite hand, which can now chin guide the mandible closed. The patient's lower lip must be pulled forward so that it does not fall into the registration. The patient is asked to relax while the dentist chin guides the mandibular ridge into the registration material. The lips are relaxed and allowed to rest against the lip support of the centric tray, while the dentist checks the vertical dimension with the previously made vertical assessment. The patient remains in this position for approximately 2 minutes until the material has set. There should be a reasonable recording of the maxillary and mandibular ridges, and preferably there should not be any areas where the tray has poked through the putty registration material.
We have a centric tray, and the centric tray is a very nice tool. These all come off, so they slide on very nicely. Here, you see the cupped areas. This is just to keep the tongue down and out of the way. And now what we're going to do is we're going to take some silicone putty, and we're going to mix this putty, and we're going to mix like 3 scoops of putty, 3 catalysts, 3 bases, put them together, and we're going to make like a hot dog, and we're going to place it on top, and then we're going to turn it over and place another piece on the bottom. And then we're going to pinch the end, and then we're going to place it back in the patient's mouth. We already have our measurement. Let's say we decided it was going to be 65. So all we're going to do now is we're going to have the patient open, we're going to place it, but we're not going to seat it. We're not trying to take an impression, but we're just going to place it in the center. And then we're going to slowly have the patient go close, 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 close until we get to our numbers. So you have to tell the patient, don't just clamp down on this, but go slow. And you'll just say close, close, close until they get into that position. And now you've created a beautiful vertical so that you can send this to the laboratory and they will turn around and they will mount this. So we take this and now we've got this beautiful impression, really. I mean, it almost takes a gorgeous impression, but it's polyvinyl siloxane. And so now we got to cut away all of our undercuts and all of our hard tissue areas because we want to be able to just barely let our crest of our ridge fit here. So we don't need all of this area. So we'll just cut all that away and make sure that this fits down there and does not get interference anywhere. So it's like here, I'd probably cut a little bit more of that off here in this area here so that I make sure that's not keeping me from seating this, because it's so important to get this right now, because that when it comes back from Kelley Dental Lab to you, you're not going to have to touch it. I mean, you're going to be just totally surprised. I know a lot of you've already done dentures and you may have already decided you're never going to do another denture, but you're going to find out this really is so nice and easy and simple that it really works. Now we're just going to mount it. I always use a semi-adjustable articulator, but it really doesn't matter. All we're wanting is this space. I'm just wanting that space right here. So we're going to turn around and just put it on a simple articulator or semi-adjustable, and then we're going to build the upper occlusal rim or the ECB to your measurements, and then what's left, we're going to make the lower occlude against it. I don't know how many times you've entered and put something in someone's mouth and they're hitting wide open. I'm going to show you a picture of that in a few minutes. It's amazing how they hit in the back first, because that's exactly the way we come together. We're opening the anteriors, and the back is a very closed area back there, and it wants to hit first. So you would hit on these, and then you have to start adjusting like crazy. So we turned around and used the denture gauge and the papillometer. We took this measurement here, and we got an incisal length, and we also got a labial position. Kelley Dental Lab made your occlusal rim to match that exactly. And they made your occlusal rims for you. Now I also go ahead and I actually put, I don't call them midlines. but I go through the middle of the incisor papilla, and I go all the way down through the medium raphe, and I find the palatine pareve, and I kind of split in the middle. So I do a straight line all the way down to the palate, and I just transfer that line over on my labial of my maxillary, and I also do it on the lower and follow all the way down on the lower. I do this so that it's easy for you to see if the patient is deviating. When you put these in the mouth, if you've got the lines already drawn and they start moving to the left and to the right, you can see that. And so you'll know to let the patient sit there for a few more minutes, let them deprogram, because they're probably wearing an existing denture that they're overclosed or they're coming forward. So you want to try to just deprogram them a little bit. I love intraoral tracers to deprogram, but a lot of the doctors say they just don't need it. So, we don't always do that for you. But if you do want a tracer, I know Kelley Dental Lab can also provide you with an intraoral tracer to deprogram your patient that you can't get a good bite on. Does this work? Well, let's look and see how this procedure works. If you look at the patient on the left here, you can already tell here, we've already done a little bit of the vertical. We opened this patient up by using some tooth color acrylic on an existing denture. Most of these patients have 4, 5, maybe 6 even dentures that they've had in the past. So I always like to have them come in. We like to take some tissue conditioner, put it on, and take a little bit of impressions there, and let them wear these existing dentures for a while. These aren't the dentures that they really like. These are just a pair of dentures that they had extra because we're going to make some changes on it. We want to make sure the patient knows they're not going to get these back in the same position when they brought them in. So we put a little bit of acrylic on that, opened up the vertical. But what I want you to look at is the incisal edge. The existing denture is showing about 1.5 millimeters here. And when I put it on the denture gauge, I want my anteriors touching. If you can look at this, the posterior is not even touching. In fact, you can see there's so much bone loss. I mean, the palate is actually as high as the labial part of the vestibule here. I mean, it's just amazing for all of that acrylic. But I have the anteriors touching. I just push down into the incisor papilla, making sure the edges are touching. I get 17 millimeters. We make the occlusal rim, send it back to you, and I want you to look. It's exactly what you asked for, and you're not going to have to touch it. I mean, that is just totally incredible, and you're going to really enjoy doing removals again. All right, so now let's look at the papillometer. We measure the papillometer. Look at this, 17 millimeters. Will it always be the same? Always will the denture gauge and the papillometer match? No, not always. Majority of the time, they do. If they don't, let's say I had a papillometer of 17 and I had a denture gauge of 20. The real nice thing about that is it makes everybody stop and go, okay, wait a minute, which one do we really like? So if the denture gauge was the 21, you put the existing denture back in the mouth, have them speak, have them father 55, 56, you'd have them say 60, 61, 62 to see if the teeth are bumping. And that's how you know if you violated the inner arch spacing and all of that. And you can make a determination. Do I like the papillometer measurement? I like the denture measurement, denture gauge measurement. So this is why I like to use both. It stops you. If the patient comes in with no dentures, of course, you're going to have to just rely on the papillometer. The only thing with the papillometer, it gives you the length. It does not tell you how far out that you would want to bring your teeth. Then you would have to wait for the occlusal rim. And usually, if I don't have any measurement there, I usually always like to come about 7 millimeters from the center of the papilla out labially. So that's how far labial I'll come with the occlusal rim. So I just make sure it just protrudes just 7 millimeters from the center of the papilla. So now I did the papillometer, brought it back, and look at that. Kelley Dental Lab did a great job. You're just going to be so surprised and happy. And of course, Kelley Dental Lab is very happy that you're happy. Next, we're going to talk about the denture tooth selection. Now, if you look at this picture, of course, these teeth are a little bit too large for this, and everybody makes it so difficult to be able to do this. But The problem is we've been taught an old, antiquated way of trying to figure out the width of our 1x6. If you look at this, it's amazing. This is what we've always been taught. You know, do we want square teeth? Do we want square tapering? Do we want a square ovoid? Do we want a tapering tooth, a tapering ovoid, an ovoid tooth, or do we just say the heck with it and we'll put in a square tapering ovoid tooth? I mean, this is why most of the time, Kelley Dental Lab, my laboratory also that I used to have, majority of the time we pick out the teeth. We do that by you take an impression of the existing dentate cast and an impression of the existing denture or the upper denture and the lower denture, and you send it to us, and your prescription usually says make denture, copy cast. And then we go and pick out the size of the teeth, the width of the teeth, the shape of the teeth. But I'm going to show you in a few minutes a beautiful technique, and your patient's going to help you pick out some teeth. And you're not going to do it all by yourself. The patient's going to help you, and I think you're going to like it. But you also look at this to get the width. If you look at this, you had to mark the corners of the patient's mouth, and then you would take the ruler, the millimeter, and you would measure from that point to this point to find out how many millimeters you needed. The issue with this is if the occlusal rims are just made normally 22, 18, and then and they're just put up around on that ridge, you're not going to know whether or not your support's good or not enough support, the size of the edge. It just takes you a lot of time. So this is totally antiquated. I would never do an occlusal rim if I could not make it customized for the patient. So let's see, what's a newer way? All you really have to know is the width of the 1x6. So we're going to show you a way that you can figure that out very quickly and easily with the patient. Then you got to know soft and bold. This stuff of square tapering, tapering ovoid, ovoid, and they teach you that you're supposed to look at the face. You know, if their face is square, you use square teeth. If their face is ovoid, you use ovoid teeth. If they're ovoid tapering or tapering ovoid, you use tapering ovoid. Well, you know, unfortunately, as I've gotten older, I have gotten a little bit rounder. So does that mean just because I've kind of eaten a little too much and I've gotten a little bit older that now I'm supposed to have ovoid teeth? It doesn't, you know, that bucket doesn't hold any water is what I always like to tell everybody. It doesn't, it's just something that we had to learn, but I don't like it. I don't think we need to do it. If you look here, soft and bold. Well, what does that mean? Well, if you look at teeth that are soft, if you look at a person smiling, if they have curved distal incisors, they got a nice curve here in the central, they've got nice open embrasures here, everything's curved. This lateral's maybe a little more forward of the central there. That makes it soft. When you look over to the bold side, I mean, you can see the embrasures are pretty well closed. It's just kind of a square edge. It's really bold. The lateral is almost flat. And then you turn the corner with the canine. This is a bold look. I like to do soft and bold with the character of the person. If your patient is a very aggressive person, I can set their teeth, Kelley can set their teeth exactly in an aggressive manner that would be bold. If you have someone that's meek and mild, whether or not they're male or female, has nothing to do with male and female. In fact, most of the people say, oh, I'm going to use this on the female. I'd use this side over here for the male. That's not also, it's not correct. So just personality. I think you'll be totally surprised if you go by personality. The patients really, it changes their smile and they really enjoy, you know, having a different look. They're buying new teeth, but yet we give them always the same look because we're afraid that if we change anything, that we're end up having given the money back. But most of the time, the people, the only thing they know what they look like or what they want is what they've looked at every day for however years they've been around. So you give them something nice. In today's culture, everybody wants a new look. You know, nobody wants to have gray hair. Everybody wants to do nice cheek implants. They want to do a chin implant, everything. They don't quite want to look the way they do. They want to look younger, more vitality going. So this is the things that you have that opportunity to do. And then I got to know the length. So all I have to know is width, soft and bold, and length.